Okay, so today, thank you for joining me today, Dr. Seemab. I really want to introduce you to some of my colleagues as an ENT that's very integrated from India. I'll describe a little bit about how I met you first, but let me allow you to introduce yourself and where you're from.
Hi, Shereen. Good morning. Good morning to everyone. I'm Dr. Seemab Shaikh. I'm from Pune. It's a city in India which is called the Oxford of the East. So we're like an educational hub. I am an ENT surgeon. I head the department at one of the major multi-specialty hospitals here in Pune. And I mean, it's been almost 2 decades now that I've been working in the field of sleep apnea. And I think as we've grown over the past 2 decades, we've also come to realize that it's not just about any one faculty. Like I'm sure everywhere in the globe, we have come to that understanding that it's got to be a very, very integrated approach. And there are many, many fraternities, many, many faculties that are involved in the treatment of obstructive sleep apnea. And I've also actually, this year when I was awarded the national level oration at our country, I made a very, very strong point to mention there the role of the dental community in the treatment protocols. And I really think that's very important for everybody to recognize that both in the pediatric as well as the adult age group.
Yeah, for sure. We need greater integration, particularly between ENTs and dentists as well. And so one of them, when I first met you, it was actually online. I was involved in a talk with India. It's a panel discussion with myself and a pediatric sleep physician. And one of the questions that was posed to both of us to outline our approach was, how do you manage a 6-year-old child who is snoring? And you jumped in and contributed your answer, which was fantastic. It totally resonated with my own approach. So can you share what would you do for a 6-year-old?
So, Shereen, generally the approach from an ENT perspective has to be always quite complete. So earlier we would probably look at it just from the obstruction point of view, from the airway itself. And basically pediatric OSA is generally a clinical diagnosis. So I don't normally ask for sleep studies in pediatric age group, unless of course I am hearing a history from the parents, which is like extremely difficult from the point of view of the quality of life of the child. And when I'm actually examining the child, I'm not finding that the tonsils are beyond, say, grade 1 or grade 2, or there's any signs of obstruction that way. So if there is a disparity between what I hear and what I see, is probably when I would ask for a sleep study in children. Or at the most, if I find that there are some kind of neurological issues that are there in a child. Of course, needless to say, syndromic children, yes, I think most of us agree on the fact. So the approach generally is very clinical. When the parents would give me a history and say to me that he is mouth breathing, he is snoring, he is a little hyperactive, and probably one of the most important things that I kind of like to ask them is his scholastic performance or is his school performance by any chance going down over the past year or so? So that's how I initially approached the history part. And I'm actually blessed to have a pediatric flexible scope in my OP. So sometimes it's quite easy to, if you have a cooperative child, and most of them do cooperate because it's not very difficult to pass that scope in. And you're able to see a very hugely blocked adenoid. So the writing is out there on the wall. Then you know that, okay, this is a tonsil and an adenoid causing a pediatric OSA. And then you start approaching it that way. But what has changed in the past maybe 2-3 years or more is the fact that we've started, or at least I definitely have started, and I propagate this fact to everywhere that I'm able to spread the word, is the fact that we do look into the dentition and I do look into the palate, the hard palate part. And if we see a high arched hard palate, then you obviously know that this is not something that has to be left just like that. It needs attention. And it's common sense that the floor of the nose is the high arch palate, or is the palate. So if you have a high arch palate, your nose is not going to be very roomy. So even if I do remove an adenoids and stuff like that, to make the nose roomy, it does warrant expansion, a rapid expansion. So my general way of approaching these children and the parents, because see what happens is if I do make a clinical diagnosis of an adenoid or a tonsil and I do advise an adenotonsillectomy, uh, I'm sure every parent needs time to think over it. They're not going to say an immediate yes. Even those that come across to me for second opinions, third opinions from somebody, they want to digest what is being told to them. So it takes them a while. And that's the time that I actually, that time frame when they are thinking is when I actually impress upon them the need to see the dental community and the need to expand the maxilla, the rapid maxillary expansion. Because like you all know, it obviously is a longer process. It's a process that takes about 3-4 months. And the process of an RME does not interfere with my surgical intervention. So even with the appliance in place, I can do a surgery and the RME expansion can continue even post-surgically. So I impress this on the parents very, very, firmly that while you are waiting for whatever you want me to do, at least make sure you start an RME. It's non-invasive. It's not going to be, affecting your child in any way. His routine doesn't get affected. There's not even a local anesthesia most of the times that is needed. So you must start that. And then I give them an idea of the understanding of how straightening out the palate is also going to help his breathing. So my approach is very clear cut. It's a clinical approach. If I can put in the scope, wonderful. There are children sometimes that you cannot scope. Then in that case, I ask for a lateral cephalogram because that gives us an idea of the adenoid. And then I go ahead and counsel them for the surgery part along with the RME as and when I see.
Yeah, I mean, from my perspective as a dentist doing a lot of these, there's probably only one type of patient that I probably wouldn't jump in and do the expansion first, and that's the child that has super obstructive tonsils and they're really struggling to keep their tongue up and have their mouth closed, because these children are more likely to have a bit more issue adapting. But if they have an obstruction, yes, I totally believe that we can start with expansion first because that's quite impactful. Over the last few years, when you've started doing it, what are some of the improvements that you've noticed in these children, and have you been able to avoid certain surgeries that you have initially proposed?
So I won't say that I've been able to really avoid the surgeries because again, so this could be a little skewed in the manner that I speak because most of them that I see are generally grade 3 and grade 4 adenoids. So it's not really likely for them to avoid surgery. But definitely I've seen symptomatic improvement in a lot of children while we are waiting to do something. So parents are sometimes in two minds and they tend to wait, at least in our country, they tend to wait for school holidays to get surgeries done. And school holidays are then spread about at least 6 months apart. So you have May holidays and then you have the October holidays. So generally you get to see those children between May and October and you realize that they are definitely improving. I do hear a lot of parents telling me that he's sleeping a little better, his snoring has gone down a bit, and that it definitely does help. And this is not just subjective improvement. The dental colleagues who are doing this kind of work for me are able to then validate it with proper documentation. So we see the pre-RME and we see the post-RME photographs, X-rays, I mean. And we see some of them who require dome. So accordingly, we have actual data and actual proof to see that the airway has improved. And that obviously makes things a lot easier for the child because the quality of life improves while they're waiting, if at all they're waiting.
Yeah.
And even then what happens is there are many times when post-surgery, the mouth breathing would still remain. Either as a habit or because the airway is still a bit blocked because of the nose. So that mouth breathing gets totally alleviated once you do a dome or an RME.
Yeah, I think I agree with you. I think there are parents that put their children, they decide to have the ENT surgery, but it's not uncommon for people to come back and say, oh, I'm disappointed. It wasn't immediate impact. So to have that process going at the same time can sometimes be a good option for children. And
And
so,
I think it's very important
yeah.
for a lot of ENTs to understand that this counseling has to be done pre-procedure, pre-op.
Mm-hmm.
If you try to counsel them post-op, it doesn't have the same impact. It's
Yeah.
like, oh, your surgery didn't work, so now you're asking us to do something else. So right in the beginning, if you have a complete picture given to them that it's not just the adenoids and the tonsils, but it's also the bony part that's creating a problem,
Mm-hmm.
then they are more accepting to the continuation of the treatment with RME.
Yeah, fantastic. And really, I really want to highlight various leaders in Asia like yourself, because I think personally, what I'm finding is that a lot of ENT specialists, they don't have the time to discuss this with their patients. And so I'm usually seeing the patients after the fact with the disappointing results or the relapse of treatment. And so I feel that we can get a lot of inspiration from people from different countries. And India is one of the places that I'm most excited to be a part of, because there's been so much interest and lots of invitations. And so I hope to work further with you in the future. But yeah, can you just share before we jump off, what are some of the initiatives or efforts that you're doing to promote greater integrative treatment?
So we have this association here, Shereen, which is the Indian Association of Surgeons for Sleep Apnea, which I was the founder president way back in 2012.
Mm-hmm.
And what we did was initially it was a lot of ENTs, but then we started the associate memberships and tried to involve all the other fraternities that deal with it, which would include the dental community, the Max Fax people, the neurologists, the pulmonologists, psychiatrists, nutritionists. So we tried to integrate everybody into that. And beyond that, what we decided to do was the fact that, we have to talk to all the people rather than have multiple associations and, each one doing their bit, no doubt. But if we all come together on a common platform, so we started inviting them to talk to us on our platforms, and then they started inviting us to talk on our platform. We started doing instructional courses where we involve the dental community. We started doing bony work with the MaxFax people in adults and pediatrics separately. So it's a lot of effort, yes, but it has to come from everybody together once we realize that this is not just one person's domain.
Mm-hmm.
And, like you said, all this has to happen at the beginning when you're treating a patient, because that's where our results and statistics then don't come across. So I remember that, maybe about, say, a decade back, we used to have a lot of discussions about why adenotonsillectomy fails as a treatment for pediatric OSA.
Mm-hmm.
And one of the reasons I think, like I said, it fails is because we have not counseled in the beginning. We have not spoken to the parents before with regards to RME and stuff like that. Because when you do that, then your procedure is not labeled as a failure, but it's more like a multi-stage procedure that we are supposed to do. And the parents also realize that, okay, we're going to do this first, and then we've got to follow it up with this. And the patient is not labeled as a failure. So our statistics overall across the globe would be a lot less, negative if we had this integrative approach where the patient has to have something right from day one, the understanding that there are going to be multiple people involved, and it doesn't just end with the surgery. So the minute you say, okay, this is it and this is surgery, then everything depends on the results of that surgery. And if that has not been very positive, then you get labeled as a failure. So I think to prevent this kind of misinterpretation of data, it's extremely important that our initial counseling, initial assessment, and initial involvement of people is very important before you even touch the patient. And I think we are coming up with a concept, just like we have the cancer board. We'd like to promote the concept of a sleep board, where multiple specialists would come on board before you actually start treatment for a patient. So
Yeah.
we're doing these efforts, we're taking these efforts. And in fact, even next week, this weekend, I'm talking to the Pulmonology National Conference also. And we hope, and we have been doing this. So I think everybody is now in the acceptance that I am not against CPAP. I'm only there to try to help and make CPAP efficiency better.
Mhm.
And the pulmonologists do realize that before putting a patient onto the CPAP, you need to scope it so as to see that there is no, say epiglottic obstruction or other obstruction. And the same applies to children also. So
Mhm.
yes, it's an effort. It's been going on for a while, and I would propose everybody should be involved in this. And I would love to interact with you, Shrimit. The kind of interaction that we've had in our past, although virtual, I'm looking forward to having that when we meet physically at some conference.
Yeah, definitely. And you know what you said about the success of surgery, it's the same with dental interventions as well, because there are people that will say, oh, you don't have any randomized control studies to validate that orthodontic intervention is helpful. But the thing is, usually people need a multiple approach. It's not just the one problem. We have to look at each individual, you know, look at their individual risk factors as well. So yeah, super to connect, and definitely looking forward to future collaboration and just highlighting what you do.
Always a pleasure, Shrini.
All right.
Always.
Thank you so much.
You have a great day, and
Yeah,
we will connect soon.
thank you.